thank you, Andrew, for the book, and this Professor Dimitri and Maya, the Dean. Thank you all for inviting me, having me here. I'm deeply honored, as I said yesterday already, and I'm enjoying so much Georgia's hospitality. I know it's legendary, but it's wonderful. And I'm so much looking forward to my next visit already, as we just talked about it. So let me start with this little bit provocative title, AI-guided surgery. Andrew Gums just had a wonderful talk on AI surgery, and I like to sort of start with these hopes and dreams that we have in AI-guided surgery. And also by Professor Schlitt, he presented also what is possible in the very near future, and what will improve the results for the patients. Another thing is that we're all aging. Aging, in fact, is a disease. Though, as we know from the centenarians, and I was just in Okinawa, Japan, just to see how they age. They age slowly, obviously. There are many, many centenarians playing in the grounds, any type of ball games, and if you look at them, that is really astonishing what can happen with human beings, slow aging. With the age, associated, though, are diseases that we die from, and that's the problem. So we have underlying the aging and the process of accumulating changes in the cells, and then come diseases that we have to fight as doctors. So how not to die of ovarian cancer is provocative, because so many of the patients actually die, more than half of them, way more than half of them. And so this is something that we have been working for a couple of years. For many years on ovarian cancer and how to improve. First and foremost, this is improving surgery, and without the help of many disciplines in medicine, but particularly also the general surgeons who taught us, gynecologists, and particularly me as well. Without that help, we probably would have never gotten that far. So how does a surgery, gynecologic surgery OR looks like today? And what we can see, screens and screens and screens, and sometimes other disciplines come and visit us. What are you guys doing here with all these monitors? Yeah. So, but we need during surgery lots and lots of information, and it's almost not enough. And it's also, as we can see here, not user-friendly. This not being enough, we have augmented reality, like here. This is already 10 years ago, or more than 10 years ago, when we used 3D. We started with the 3D, when we also started with the Da Vinci. This is 3D for the laparoscopy, to be even quicker, more precise. And also miniaturization, meaning with using instruments of only 3 millimeters in diameter, and in ovarian cancer, that's probably the application rather for staging than for debulking, obviously. So in ovarian cancer, this is the typical situation. Basically, you need your eyes, your hands, maybe your nose also, or sometimes not. But it's very a surgery in a way, of a pretty old style, though it works. So, and this is the gold standard. So, we have also the opportunity to use the robots, but that's minimal invasive surgery so far. And again, that is only for staging in ovarian cancer cases. So let's look at the significance of cancer altogether. It's the second leading cause of death. So, of course, 100% are aging, but but we don't die of age. Yeah? We die of diseases. So, worldwide, 10 million deaths in 2022 WHO numbers, and very interesting, 40 to 70%, depends on the societies, of cancer-related death are preventable. And this is also true, which I will show you, for ovarian cancer. So what a potential we have here. So it's preventable in more than half of the cases, and that is linked to modifiable risk factors. In ovarian cancer, we see fifth leading cause of cancer death in women. 90% of ovarian cancers are high-grade serous. So that is the subtype. So it's pretty uniform. And 96% of these high-grade serous cancers contain p53 mutations. I will show you. So what is then the potential here for a disease which usually is only diagnosed in later stages, in the advanced stages? So what is the potential here for AI? Because you just open up the belly, basically, laparotomy, and I will show you some pictures. I hope we're all medical doctors here, nobody is offended by this. Well, this is pretty old-fashioned surgery, classical surgery. What is the potential, though? First, risk assessment. We need risk assessment. Who is at risk? And we then have a chance, maybe, for early detection. So that could improve by a quarter the survival rates, because early detection means 90% survival. And if you have later stages, which is almost all of them, they have maybe 30% survival. So this is the difference of 60% in the survival rate. And then we need to go on hyper-personalization, integrating data from the genome, microRNA. Katie is here, she works on this subject, Katie Zumaya, proteome, epigenetic methylome, clinical data. We all integrate this we can't do that by ourselves. We need to integrate that for those people who treat the patients, so also us as surgeons. And the surgical outcome can be also improved by AI, by real-time data in the OR, but also, of course, in preparing for the surgery. What about the modifiable risk factors and the non-modifiable? Non-modifiable, of course, if you're born with BRCA1 mutation, by the age of 40, your risk starts for ovarian cancer, and the lifetime risk for ovarian cancer is about 50%, sometimes higher, and for breast cancer, of course, for the breast cancer gene 1 carriers, it's about 70 to 80%. So, but if we look at the modifiable risk factors, I like to direct your attention to one study just published, dietary inflammatory index, that was checked. And it was found that women with a high dietary inflammatory index, so their diet is obviously not a Georgian diet, they will have a 47% higher risk, only by diet. So plant-based diet, as we have it here in Georgia a lot, will help to reduce this risk and can reduce by 50%. So this is extreme. We have to keep this in mind. And so, how to predict and to prevent a disease deadly like ovarian cancer? So we can identify, of course, new risk factors with massive amounts of new data, which AI analyzes, and this is already underway. The models are being trained for this. And then to detect certain patterns in genomics, in metabolomics also. And this will help, of course, early detection. But if we had the information who is at risk, we still have the problem we don't have early detection, because from UK we have a large study, UK CTOX. 200,000 women were included prospectively, and they had the combination or single-wise ultrasound plus the tumor marker CA125. And the combination didn't work. Almost nothing. Like from stage 3 to stage 3C to 3A, some cases. It just didn't work. You didn't get them to stage 1 where you can have 90% and more of survival rate. So this has been demonstrated in this wonderful study. So we need early detection, which possibly can be done, and I will show you examples which way we can go, and by which AI will help us, and this way we can predict and probably then prevent. The incidence rates throughout the world here published in Georgia also belongs to the here in darker colors to the countries where you have 10 in 100,000 per year who will have the diagnosis, and which is a high incidence country, and more than 6 will die from it every year of these diagnosed patients. So that's the statistics as we have it similar in Germany or in the US and other European countries as well. And most of them, as I said, are high-grade serous. And the high-grade serous, you see the middle line here, this is the survival rate. This is just devastating, and you see over the years almost no one will be a long-term survivor. Long-term is in ovarian cancer 6 years, so this is pretty bad. What about aging here, and how does this, is this an underlying problem? There are 12 hallmarks that's being published in Cell last year, 12 hallmarks identified, and this is an expanding universe. Actually, one of the major problems is genomic instability, which already starts early in life, already in newborns, in fact, and I will show you in a minute. And one of the major factors, in fact, is the p53 tumor suppressor gene, which stops the cell cycle in the G1 phase, and that allows for repair. So you need repair, and if repair doesn't work, okay, you also have a problem. But let's start with the p53, and I started here in the early 90s, and at this great institute, Jonas Salk founded this. Jonas Salk, you can see him, I try to show it with the cursor. This is Jonas Salk, and this is Renato Dulbecco. He was my boss at the time and mentor. This is me shaking hands here at a party. And Renato told me you should work on p53. This is the new thing. He got his Nobel Prize for identifying viruses that cause tumors and cancer. But what about the opposite, how to prevent it with P53? He asked me to work on this in breast cancer. And Sarah Sukumar, you can see here, she's at Johns Hopkins today. She was sort of my supervisor and also mentor, and she's a professor at Johns Hopkins. Well, the P53 regulates, as I said, the cell cycle and allows for repair. That's causing genomic stability because all the time, if you expose yourself to sunlight, you get in the UV light, you get right away mutations, and that P53 gene can help to have it repaired. In ovarian cancer, we see that there is a loss of heterozygosity, meaning you lose one arm of the chromosome, which contains mostly the P53s. This is on 17p, and the other copy will then be mutated. And Dimitri, I like to cite one of your papers here. You actually said in ovarian cancer, it's a marker. You can already say this is in high-grade serous cancer. This is a marker already right there. So it should be used widely for actually diagnosis. And this very busy slide, I'm very sorry, I just had to copy it right out of the Nature publication, shows us something very nice. I think, to me, this is last year, published in December, probably one of the most important papers published in medicine, at least from my perspective. They analyzed 5,600 subjects. These were 4 cohorts, very well described, and they used it at Stanford. And they had almost 5,000 proteins which they looked at the expression, and they decided which of all the proteins are actually highly expressed in certain organs, like the liver or other organs. 11 organs they looked at, and then they looked as to what happens during aging, and a little bit augmented here, we can see chronologic aging, and with the aging you can see that some have higher expression or lower expression, and then they could find out that organ-specific you can have aging. For example, a kidney ager, an extreme ager, maybe even. And they found that 20% of the population, of a very representative population, are extreme agers in multi-organs. And probably those are the ones that give us also a chance then to advise them maybe to a different lifestyle. Maybe no smoke. I'm not talking about wine here, but let's say diet otherwise. And another interesting observation with the P53 gene in the last few years was, and partially this is not published yet, that in the tubes you will find P53 mutations, actually not on the ovary. And Crum and other pathologists then came up with a hypothesis, maybe the ovarian cancer comes from the tubes, all right? And more this observation is now substantiated, and what you can see with the in situ carcinoma just sitting there in the fimbria of the tubes, you can see P53 mutations here shown with the immunohistochemistry, and then if Ki-67 comes with it and goes up, so proliferation goes up, then you will start having a trouble. We have been doing salpingectomies for a long time already, because from Sweden, where's Max? From Sweden we got from the wonderful registries the data, and Henrik Falconer, I just visited him in Stockholm some time ago. He analyzed this for the Swedish population, and he found, and they published already in '99 that if you just have a tubal ligation you have a 30% less risk of ovarian cancer. So that was the first indication. And so then when I came to Jena, I said, with all hysterectomies, let's take out also the tubes. Why having the tubes? So looking at these tubes then by the pathologist, which is not standard to take out the tubes, we looked at these from a young patient, salpingectomy. What you already can see here is a stick in situ carcinoma. This is a little bit older patient than the first one, also in the salpingectomy p53 positive. So there are indications, and this is actually an indication of invasive cancer. So this is what's happening in the tubes. And so what we need to do is take out the tubes, cut them in the fimbria, because this is where it happens, and look for p53 mutations, or at least stabilization of a mutant protein. And this type of analysis can then show, by proteomic analysis, analyzed with the AI, that you have here a problem, in fact, a stick or even an invasive tubal cancer, which is later on an ovarian cancer. And so mutational screening can also be done, and this is from a paper, Riskus et al. They have started also with newborn and to centenarians, so people that are 100 years old, and they took the tubes and analyzed them. And what they find is throughout life you have p53 mutations, and you can take them from swabs. This is the first publication on this kind of principle by Bert Vogelstein and Kenneth Kinsler's group at Johns Hopkins. And if you see here on the right side the pattern of p53 mutations, so where in the gene happens, you can see the normal and the cancerous p53 mutations are pretty similar patterns. So they occur throughout life. Then we thought maybe we can look at the cells in a little bit different way. Maybe we can do a lavage of the uterus and then get the cells and look at them. And maybe by this we can also have a clear indication and maybe get to a screening for ovarian cancer. So the next slides will be are from this guy. This is Professor Christian Eggeling. He is a former postdoc of this person. This is Stefan Hell, Nobel laureate of chemistry. He invented a new type of, Kitty will know, a new type of fluorescence microscopy. Okay, this is at an occasion where Stefan Hell gave a talk. By the way, this is Walter Rosenthal, quick reference to him yesterday, our rector at the time. And what they look at is here in the with a super resolution, you see all to the proteins itself. You can look down to the protein itself. So how does this look like? I show you in a quick by Christian Eggeling, this actin molecule. So when you look at this, please, what you see here is a mast cell. Stimulated by IgE, IgE antigen stimulation, and this cell opens up and eats something, like a virus, for example. This is shown, this is microscopy, and you can see the actin with the little dots. Yeah? And this is only possible, in fact, by analyzing these data with the AI. So if we go on from back to molecular science, then this is what we're doing and trying to get together with Christian Eggeling with his microscopy. We like to put together different approaches. This is the methylome. The methylation, as you know, is methyl groups on the DNA, and it appears random, but then it happens on the genome to actually to shut down genes, basically, and it also regulates in a certain way how transcription is being done. Usually with the age, you have a hypomethylation, but in certain instances you have a hypermethylation, and that is a selection advantage. For example, when tumor suppressor genes are shut down by methylation. So we've seen this with BRCA, we've seen this with p53 and other genes that control genomic stability. So methylation can actually act as control. And this is a control we don't like, because if you have tumor suppressor genes stopped by hypermethylation, then you have a selection advantage. And in cancer cells, we see that there are methylated areas which we can amplify with a methylation-specific PCR. So in our case, we have analyzed and identified 374 such islands of hypermethylation, and we looked at the genes whether it makes sense that they are possibly shut down, because this is at the promoter region of the gene where the methylation happens. We're further now identifying which genes might be predictive of ovarian cancer, and also which are predictive of a bad outcome. And what we can see here is that it is predictive, some of the factors that we have identified. And if you scale this up, then you start to need the AI help. And with the AI help, finally we get up in stage 3 and 4, okay, to a high sensitivity. That's easy, because that you can already see on the CT scan. But going to early stages, we might have quite some sensitivity. So we work on marker combinations. So back to the fallopian tube, what does this help us? I told you, uterine lavage, and then take those cells, look them under microscope, analyze them by the genome, the methylome as well. But as long as we don't have anything, we're stuck, or we take out the tubes. Which may then reduce the risk for ovarian cancer quite a bit, actually significantly. So we're stuck with all these things happening, which is the aging process, and the prophylactic surgery could look like this. I start just showing you a very simple procedure, but this is something that actually could possibly also be done by general surgeons. Why not? I mean, they would say, such an easy procedure, but yeah, it's a small step, but for the patient, maybe a giant leap. So what you can see is a very simple thing. I try to show you here. What it means, it's cutting, it's coagulation, cutting, and so on. It's real quickly done. It takes maybe a few minutes at the most. So what we looked at the German data, we retrieved them from the Federal Bureau, where these statistic data are gathered, not like in Sweden. And we looked at hysterectomies. During the age they are done, 40-year-old, 50-year-old women hysterectomized. These are options, or other surgeries which are eligible, cesarean section, and so on. Of course, with completed family planning and scheduled surgery, patients need to be advised, and so on. But we also asked our friends, what do you think in surgery, in general surgery, what could also be eligible? Well, cholecystectomy, hernia closure, bariatric surgery, appendectomy, maybe, if it's eligible. So altogether, we put these possible data into a Markov model, which the AI can much better work with than we can do. And we put this in the Markov model, which compares two states, healthy versus not healthy, or healthy versus at risk, and so on. And we come up with this complicated slide. Please don't look at it. There are different strategies that you can have then, that you have an opportunity where you can take out these tubes. And if you take them all, that is a strategy, OS, opportunistic salpingectomy at all eligible abdominal surgeries. And what we end up with is that this Markov model spits out the data of 15% prevented ovarian cancer cases with a surgery that's almost nothing. So 15% of women of whom you can actually prevent this deadly disease. So coming back to surgery, AI can assist surgery in many ways, as we heard by Andrew Gums. Decision support, all this kind of preparation before you start the surgery, but also during surgery. This is where we do a staging laparoscopy here in ovarian cancer. This is a friend from Rome. But anyway, you can see all kinds of data, like here, radiology data, anesthesia data, all this kind of data, what we can have during surgery. But before, we can probably also use we have to use the pathology data, and which are more and more being analyzed by AI support. And this shows that there are multiple layers. There are more than 40 monoclonal antibodies put onto this, and there is then the AI to find out what subtype of cancer are we working here with. And that is already a great support for us to decide what to do with the patient. And all this data integration with the medical history, with the genetic data, comes out, and we finally then can decide. But also during surgery, and this looks like a totally classic surgery, but if we had a context awareness, like somebody telling us, hey, this patient, if you do this procedure now, take these implants from the liver, take them from the diaphragm, as in this case, you will need, we know that you will need another 2 hours maybe, or another hour, whatever. And the patient is exactly at this stage of a condition such that with all the vital signs and many more data, you will end up not in the ICU. This patient has a great risk of maybe even dying from this procedure. So this is context awareness that we nowadays can get from AI. Going back, this is almost, I think this is 10 years ago with the first SI Da Vinci system. So all the patients ask us all the time, well, is this sort of a cognitive robotic system? What does the robot do in my body? Yeah? So there's a great fear factor. Andrew, you just mentioned that as well, that autonomic driving may cause problems, but this kind of autonomic driving inside my body, no, please. So it sounds modern, but sounds also quite fearful. So with the new system, there's some new ergonometry, so it's easy to use with the Da Vinci platform, but a spokesman from Intuitive just again told the public, this system does nothing on its own. It still does nothing on its own. So the autonomous level of this, I don't know, is that a 2? It does not the task by itself. So don't, well, in a way, it is right now being trained in many centers, such that at least the strategy with the human is being developed. So you have a strategy like where to cut in the detail, where to in cholecystectomy, for example, they did this, this kind of training. So cognitive robotic training, so that would be like you have some sort of almost consciousness of the robot. That is far ahead, and this is not what we're talking right now. But the learning process, and this is the learning phase for the robots, is right now on our way. And so that probably will then have more precision than with humans, and some error will be eradicated by this. So in terms of learning, this is just one example. This is from Dresden in Germany, from general surgery. They showed how they were training their robotic system by data collection, data processing, machine learning, and this was just to show that the machine can learn to recognize a structure like the bowel. And here we can see simple repetitive things like suturing. In this case, the small bowel is as a model here. They have done this in the pig model as well. That actually works. So we're not far from the point. Intuitive says we're 5 years at least away from this. It doesn't look like that, because we are in predictions with technology are always thinking technology is linear in the development, but it's not. It's actually, over the past 80 to 100 years, it has been, and it's shown, it has been exponential. We cannot think of what is happening in the next few years in terms of autonomous surgery, I think. So for breast surgery, that's nice. It's on the surface, and here you can do minimal invasive like lumps that you take out, and this can be taught to the machine, and there's probably little harm that can be done. But what about teaching? I think teaching is a very, very important aspect, and in 2018, this was when we started as ovarian cancer surgery centers, 4 in Germany, Jena, Berlin, Essen, Freiburg. These were centers that started with a program to teach classical surgery and also nowadays robotic. So this is a classical laparotomy in a FIGO stage 3C ovarian cancer with the omental cake. This is also this is en bloc resection with the rectum, with some part of the sigma, the uterus, ovaries, and this is and for this for the surgery planning we need again. Precision, CT scan, MRI, but many of the things we see and or palpate during surgery are actually right now not detected by, I say human radiology, like here in the stomach or close to the liver, the spleen or the pancreas. We see implants that the CT scan and the MRI does not see. Do not see. So showing you also the lymph nodes, again, simple thing, if you have involved nodes, you need to take them out. And finally, you have a situation where you see that the peritoneum is gone and the lymph nodes are gone, which were involved in this case. I don't show you the whole thing, but what it shows you, it is really a surgery that you need to teach, and then I think this will be way enhanced. This is diaphragm, and so on. This will, with the AI, analysis of CT scan and MRI, we have a much better planning, and then we can decide who will do the surgery. And definitely, in this case, needed surgeons being very experienced. At about 800 ovarian tumors we looked at patients, and we see that in this case we have 87% of completeness of the stage 3 patients, macroscopic complete, all tumor gone. And if we look at the outcome, still it's not great. So there's maximum effort surgery, and still over the years of like 10 years, you have long-term survivors of about 20% or even less. And what is this line? This line doing really bad? Those are the ones, even when you take out all the tumor, if they had small bowel involvement, they do worse than all the others. So there is something with bad biology, what we are learning. And why do we have to learn this on the patient? We need to learn this before. We need to have risk factors that show us that this situation here on the small bowel, like this here, as seen with the laparoscopy, this situation should not be operated on. So this is probably then a situation for more for regional therapy combined with chemotherapy. In this case, with good data for HIPEC, for the interval debulking, and we need biologicals. In this case, we have been experimenting with the p53 adenoviral gene transfer. This is from early on, a paper from the early 2000s. These were 3 groups, we in Germany and 2 in the US, though it was too expensive at the time. So our phase 2-3 trial, we had to finally then stop it, even though we had very promising data, I must say, what the outcome is. Anyway, so we need to combine biologicals to get such improved progression-free survival and overall survival as we can see it here. And my conclusion is, as to how not to die of ovarian cancer, we need prevention. And we need early detection methods, new methods, like with getting to these cells by uterine lavage maybe, and then genomic risk profiling. Then personalized and hyper-personalized treatment. Enhanced surgical outcomes will come probably from an AI-assisted operating room. And so what can AI do? It can add to the precision and personalization, real-time assistance, like awareness of the whole situation in the OR, in the situation of the surgeon, and predictive analytics as to which treatment strategy is the right one and which study should the patient go into. So you may think AI is of no higher intelligence. Okay, it can help, we think. And I would like to finish with this by Banksy. So this could be possibly transferred to the AI situation as well. Thank you very much for listening. Thank you so much, Dimitri. Thank you here in Georgia for having me here. It's a great pleasure and definitely a super great honor. Thank you.